Today we're going to be talking about functional medicine in the sense of a cardiovascular event or a stroke, how we can prevent them and manage them through a functional medicine lens. I'm Carter Gansky. I'm a student physical therapist, and this is basically used for educational purposes and is not medical advice. To begin, a fun fact is some research shows that consuming 3 to 4 cups of coffee is associated with a 21% lower risk of stroke than no coffee. So get your caffeine. So the problem here is that by 2030, another 3.4 million people are projected to have a stroke in the United States. And then after a stroke, a fourth of those survivors will have another event. So the question that I pose to therapists is like, what impact can you make? And so through a functional medicine lens and through the American Heart Association's recommendations, I found these Life Essential 8 from this resource, and it basically breaks down the 8 components of cardiovascular health, moving from a healthy diet, physical exercise, avoiding nicotine, getting enough sleep, maintaining a healthy weight, maintaining healthy levels of blood lipids, blood glucose, and blood pressure. So these are all modifiable risk factors that we can use to help our patients prevent another incidence of stroke. And so really the first step forward is the knowledge of these risk factors, and then educating our patients on each one to bring them the most value and to prevent the most amount of suffering we can. Because up to 80% of second strokes can be prevented through lifestyle changes and medical interventions. So we'll kind of get into these lifestyle changes and the medical interventions you can refer to your physician to discuss. So functional medicine has really interested me because it is more of a holistic approach. So it looks at the patient as an individual and not necessarily as a group of data. So like a meta study looks at millions of people and then it says, here's the average answer. But the functional medicine approach allows a clinician to kind of dig deep into the root causes of a disease and then provides a personalized intervention for that specific patient. So you kind of have the patient retell their story, you look at triggering events, mediators, perpetrators, and I'm not certified in functional medicine, so I don't fully understand this organization of their imbalances, the mental, emotional, spiritual, but the modifiable personal lifestyle factors down here, the sleep and relaxation, exercise and movement, nutrition, stress, and relationships. By looking at those factors, we can identify root causes and produce an intervention based on average data, but applying it to the individual and their experiences and what their unique deficits are. So this is another tool that a functional medicine clinician can use. It's the timeline. So it actually goes from prenatal to birth to current life. So you can look at trauma, genetics, diet, mental health, exercise, have previous surgeries, stresses like jobs or any other past medical history like a heart attack. And then you kind of look for patterns or triggers of the disease state and where the root cause emerged and where they continue to pop up. So if you had fetal alcohol syndrome before you were born because your mother was an alcoholic, that is an important information for a functional medicine clinician to know. Or if you got in a car crash, that led to disability and depression, divorce, self-isolation, that causes stress, systemic inflammation, causing hypertension, which is a risk factor for stroke. So just kind of seeing where the patients are coming from and not seeing the person as a diagnosis, but seeing the person as a person who happens to suffer from this condition. This is also from the American Heart Association. This is just another way to view it. And so I'm a student physical therapist. So we look at the movement system in depth. And I think the movement system is a very powerful intervention to change the physiology of a person. However, the American Heart Association would suggest that there's a couple more things we can do with our stroke patients to give them the best care. So this is just kind of a visualization of how we can change somebody's diet, their physical exercise, their nicotine, their sleep, body weight, and then their blood composition. And what are the interventions that we can leverage to give them the best care. So cardiovascular exercise is extremely important because it's been correlated with mortality. So physical inactivity is associated with increased incidence of stroke. And so exercise training improves VO2 peak, quality of life, and manages risk for a second event. And this figure on the right is from the American Heart Association. And it's just kind of showing you or patients. And this resource is linked at the end. So like after a stroke, you should get counseling. You should increase your leisure time activities to maintain your quality of life. And then as we recover, we should be increasing the dosage of cardiovascular exercise and resistance training as tolerated and as safe, right? Because we still have to consider things like not valsalvating, which is where the patient bears down and they create a fluid ball in their thorax of air, and that can shoot up blood pressure. So we still want to be safe with exercise. And so we could maybe begin slowly walking on a treadmill with a harness. And for those who would like to exercise alone, consider a stress test for those at high risk and consult a physician. And one cool way we can leverage exercise dosage is at a speaking pace. So exercise at a speech comfort level, meaning that you can exercise and speak freely or even sing. That coincides with 3 to 6 metabolic equivalents. And exercise at the comfortable difficult junction. So that might be where you're jogging and you can only get 1 or 2 words out. That is the upper limit of the ACSM guidelines for healthy adults. So just kind of see where your patient is cardiovascularly and provide them a prescription based on these recommendations. So this is the American College of Sports Medicine, their guidelines for stroke, and it goes through the aerobic, the resistance, and the flexibility recommendations. Why this is important? Grip strength. So that is basically looking at the nervous system integrity and the resistance exercise for that patient. It's correlated with all-cause mortality for cardiovascular disease patients. And the cardiorespiratory fitness was found to reduce cardiovascular and all-cause mortality, as well as all of these other not so great things. So exercise is definitely key. And as a physical therapist, we know this, but we need to also look at these other factors. So I'm not going to dwell on exercise. This is the American Heart Association's guidelines for exercise for stroke survivors. So this might be more of a targeted, safe way to work after a stroke within the contraindications. And yeah, like the reality is we get patients, they're very deconditioned, they can barely walk, they might be very hemiplegic, and so they're not going to be moving very much, unfortunately. And so VO2 max might be decreasing by as much as 10 to 17 milliliters a kilogram per minute, which is really unfortunate, and it causes people to be at a level of 25 to 45% lower average than healthy individuals. And VO2 max is correlated with your heart and lung function and your mortality. So this is a big deal. And then the other thing was like 8.7% of all cause mortality was attributed to physical activity of less than 150 minutes a week of moderate intensity physical activity. So we're really not doing well here. And that's not entirely our fault, because these patients are complicated. They have a lot of things going on. This is an article that I found that kind of goes through cardiorespiratory physiotherapy. So air stacking, exercise, or coughing, all of these other segmental breathing exercises, chest expansion, and it goes through resistance exercise, inspiratory muscle training, treadmill exercise, ergometer. These are the types of things that we need to be doing with our individual patient as they present. So we have to meet the patient where they are at, because this VO2 max decline is really important. It needs to be addressed because it's a big deal on their overall prognosis. In this study, out of a little over 1,500 people, functional limited adults, found that walking 500 or more steps per day significantly decreased the risk of event. So it doesn't have to be that much. Nutrition is one of the interventions that we can utilize to reduce our risk and improve prognosis. So we found like the Mediterranean diet and the DASH diet to be incredibly important. So the fruits, vegetables, low-fat dairy, skinless poultry and fish, blah, 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 high fiber, and coffee have all been found to be good for prognosis. The other thing is protein consumption for older adults may be a little higher, so 1.2 to 1.7 grams per kilograms per day. Carbohydrate intake, general training, 5 to 7 grams per kilogram per day. This may change based on, kidney function or liver function or other disease comorbidities they might have. So work with a nutritionist to get an individual answer. The other thing is, I feel like nutritionists are very underutilized healthcare provider in these patients, because all of these things down here. So we found that people with dysphagia, so difficulty swallowing, high protein supplement may improve cognitive function, motor function, and ambulation. And then oxygen cost for exercise is up with hemiplegia, which is just one-sided weakness. It can be up to 2 times that of controls. So if you can imagine doing an exercise and feeling twice as exhausted, you're going to burn twice the calories. So we need to address that with your nutrition. I'm not a nutritionist. I'm just saying I really think these nutrition is an underutilized intervention. So we should also limit saturated fat, limit sodium, 2 grams a day. This is sodium. This is not salt. I think salt is 5 grams a day. Red meat, sweets and sodas, we all know that. And while I was doing this research, I found that there's a lot of supplements that are researched, like there's the Chinese market for CAMs or complementary modalities. I can't remember what the A stands for. But these supplements, at least in the US, are kind of unregulated, and they may interact with prescriptions, so just be wary with those. So having a healthy weight that is definitely greater than 30 kilograms per meters squared, that's a BMI, is associated with an increased risk of stroke. So we should aim for a healthier weight BMI distribution. Overweight and obese individuals are at a higher risk of stroke. So what can we do about that? Well, we know that the calories would be 3,500 for 1 pound of fat. So then we could have them decrease their nutrition by 250 calories and then increase their exercise by 250 calories. That'd be like 1 pound per week rate of loss. The other thing is, if we are restricting their calories, that could reduce their recovery, because we need calories and energy to improve, to gain muscle, to maintain organ function. So calories are very important, so we should be careful if we prescribe a restriction there. So this is the DASH diet, which is the dietary approach to stop hypertension. Kind of just goes through what we just talked about. So eat this, not that. And why I think this is cool, so it compares a Western diet with the DASH. Systolic blood pressure, that's the top number, decreased by 5.3 to 20.8 millimeters of mercury in hypertensive individuals. That is a lot of blood pressure change just with diet. So definitely a cool modality we can use there. And then going to look at sleep. So for teenagers, this is in normal adults. Teens, 8 to 10 hours is appropriate, 7 to 9 hours for young adults, and 7 to 8 hours for older adults. But when I was looking at the stroke literature, a U-shaped distribution appeared. So this was found that sleeping too little, obviously, is not great. Sleeping just right, which apparently is 6 to 7 hours for CVAs, is the best prognosis, because sleeping over that also increased mortality. So maybe look into this one on your own, because I thought it was personally going to be a little bit higher, like what the recommendation is, 7 to 8 hours. 6 to 7 hours apparently was found to be the most beneficial for our patients. So for blood pressure and cardiovascular disease, stroke risk prevention guidelines, what's normal or not prehypertensive is under 120 systolic and 80 millimeters of mercury diastolic, has been found to be the best risk reduction for mortality. And what we were saying with the DASH diet earlier, upwards of 20 millimeters of mercury change. This table in the bottom here says that a 5 millimeter mercury reduction in systolic is a 14% stroke mortality reduction, which is, that's incredible, right? So like that's a lifestyle intervention that can do medicine, basically. Also, the fourth bullet point, the chronic aerobic exercise leads to a reduction in systolic blood pressure, 5 to 7%. That's another 14% reduction. We need to be aware, though, that exercise can increase your systolic blood pressure temporarily. This makes sense because as you're stressing your body, you need more blood flow, you need more energy consumption. So we should just be aware of the individual's risk factors with exercise. And this is important because in stroke survivors, individuals with hypertension had a 67% higher odds ratio of another event. And then we should also be aware that a stroke risk is about 400 to 500% higher if you have atrial fibrillation. So that should also be addressed. So diabetes and blood glucose. So these are the definitions, if you're not aware. Fasting glucose of 100 to 125 milligrams per deciliter is associated with an increased stroke risk. And diabetes was found to be an independent risk factor for stroke recurrence. So it's a big deal. Glucose should be 74 to 106 milligrams per deciliter. Older adults is a little bit higher. Hemoglobin A1C is basically a summary of the glycation of a red blood cell of the last 90 days. So under 5.7% glycation is the goal, but diabetes mellitus is considered anything over 6.5%. And I found this interesting because the actual prevalence of hemoglobin A1C is, in older adults, it's 7 to 7.5% is the goal, and cognitive impairments and comorbidities in that older adult is 8 to 8.5%. So I'm not sure if diabetes mellitus definitions change as you age, but that's just what happens as we get older. I guess we become, it's more normal to have a higher hemoglobin A1C. I'm not sure if that's an abnormal normal for these older patients, but that is what I found. Cholesterol, total cholesterol, normal for males and females, desirable, borderline high. In ischemic strokes, there was a positive correlation, meaning higher total cholesterol, higher risk. In hemorrhagic, there was a negative correlation with total cholesterol. Actually, that's reverse. So I guess if there is a higher cholesterol, there would be a less risk of hemorrhagic stroke. Though these were kind of confusing, total cholesterol and low density lipoprotein, because there was the same inverse correlation with ischemic versus hemorrhagic. So might want to look into that yourself. Normal LDL was found to be 100, less than 100 LDL. They're the near, as you get higher, you get a higher risk of stroke. Aerobic training was found to decrease LDL, which is a good thing. And then high density lipoprotein is considered the good cholesterol, and this one was less confusing in the literature. These were the normals, and it was found that increasing it, the good cholesterol, HDL-C, was associated with an 18% lower risk of total stroke. So that's a good thing. Sociogenomics. So this is from the Functional Medicine Institute. You can check out them on the resources in this presentation, but this is just kind of looking at like social isolation can increase cardiovascular disease up to 27% in a group of postmenopausal women. And it's just kind of looking at how important social relationships are. So poor social relationships are associated with a 29% increased risk of heart disease and a 32% increased risk of stroke compared to those with a healthy or strong social connections. So it's a big deal. So getting fired, having a divorce, and then relationship quality might contribute to inflammation and parasympathetic nervous system, sympathetic nervous system balance. So definitely need to be addressing social relationships. Stress. So in our society, chronic stressors can contribute to vascular damage. And these are just some of the stats. So on average, health-related concerns account for 65% of stress. And in the US, we lose billions of dollars. Over half of Americans report feeling stressed, and we know that this can contribute to disease states. So it's something we should be paying attention to. Tobacco is a negative coping mechanism for stress. So 1 cigarette a day carries 50% of the risk of 20 cigarettes. Average users of smokeless tobacco had a higher risk of fatal stroke with an odds ratio of 1.39. And then current smoking is associated with increased prevalence of subclinical brain infarcts. So not great. So we should also be addressing smoking and nicotine consumption with our patients. And then, this is just some stats on behavior. So this is CDC. It says that these 5 critical areas: smoking, regularly exercising, consuming moderate to no alcohol, a healthy weight, getting 7 to 8 hours of sleep per night. Only 6% of Americans have all 5. So we can definitely talk to our patients as able about these interventions and kind of try to increase this prognosis for our patients, because we just saw that these are beneficial for prognosis. And then a reminder, 66 days to make a new habit automatic. So behavioral change is key. And then in conclusion, functional medicine asks, what are the root causes? What are the best interventions for the person in front of me? And then how can we translate these heterogeneous studies, so made up of millions of participants, to benefit the homogeneous individual in front of us? How can we be more effective with our interventions? So instead of prescribing cycling for 30 minutes alone, we can say, hey, maybe go try silver sneakers, do an exercise dance class, go socialize with other people your age. So always opt for a 2-fer or a 3-fer if possible. And then a social support group with strokes, dancing with healthy food. We're doing a lot of things at the same time. So that would definitely be the best way to go. So other than that, this is some of the resources, the references for the presentation. These resources are where I found a lot of the figures, and also where I found the information from the Institute of Functional Medicine.org. These are some interesting charts, recommendations, functional medicine, the gather, organize, tell, order, initiate, and track. Just another way we can practice functional medicine. And here are the other guidelines for the Mediterranean diet. And then if you would like to participate in exercise, here are some of the guidelines for CVAs. So if you found that useful, let me know in the comments, and I'll see you on the next one. Peace.